Welcome to Pareto Education's free event on Pharmacy First. This particular recorded event tackles uncomplicated urinary tract infections, which is one of the 7 conditions that pharmacists are upskilling in at the moment within the community to try and stave off and shave off any pressures from primary care. A massive welcome to you all, and we sincerely hope that you benefit from this particular presentation. And please do keep a lookout for Pareto Education's free content, whether that be online or even face-to-face, as well as paid content that will benefit pharmacists throughout the UK and beyond. A small introduction to myself. My name is Dr. Mohammed Omaji. I am a medical doctor by profession who works in both primary care and secondary care. I guess in that respect, I have best of both worlds. I've also completed a postgraduate certificate in medical education and have extensive experience lecturing both allied health professionals, including physician associates, advanced clinical practitioners, pharmacists, advanced nursing practitioners, nurses and paramedics throughout the UK and beyond. We've been very blessed in the fact that we have been able to interact with students, and we understand and really value the MDT nature of the NHS today. And we pride ourselves in providing professional courses for the contemporary student and professional. We believe in upskilling the MDT, and we specifically provide courses that focus on the fundamentals of core areas, bringing in professionals, bringing in expertise, and fostering an environment of discussion and learning going forwards. We have an extensive social media reach. I'd encourage you to join onto some of our platforms, including Instagram, Facebook. You can follow myself in LinkedIn, as well as my co-founder, Camille Khan. And you can also attend us or even invite us to your educational institute, your PCN, and these are venues that we have managed to lecture on before. So we are an experienced group of clinical educators that have educated for a number of years to the wider MDT. Now, today's agenda is to really crack through the core principles of uncomplicated urinary tract infections and to provide you with the insight and confidence you need to be able to recognize, manage, treat, and even refer, if required, patients with uncomplicated urinary tract infections. As clinicians, it's taken us a number of years to perfect our trade, if we can call it perfection. Of course, nobody is perfect, but we're consistently learning, refining, and we completely understand that our pharmacist colleagues, who we rely on a number of different areas and spaces, are required to upskill very, very quickly in areas that may seem relatively alien to them. This is why we exist, to try and bridge the gap by providing clinical education and also face-to-face tutorials to try and provide clinicians, or more specifically pharmacists, with the confidence they need to adequately see patients, manage them, treat them, and also have their conscience at rest that they've managed to do whatever they can. We also focus, and we will be focusing in this presentation, on some of the more small print areas, including documentations, effective referral, onward referral, and even follow-up in community pharmacy. So what have we got planned for today? Very simply, we're going to start off with some general principles, and then we'll start to explore some of the core signs and symptoms of an uncomplicated UTI. We'll also explore some of the tools that you will have at your disposal within the consultation room at your pharmacy, including new scoring and also urine dipstick. We'll also be speaking about differential diagnosis, as well as deterioration, onward referral, and safety netting. So what is a urinary tract infection? Ultimately, it's a bacterial infection of the urinary system. 15% of women in the UK suffer from a UTI each year, and we'll specifically look at why women are affected more than men, and this is down to anatomical reasons. They're normally uncomplicated infections, and these normally resolve with some self-care and antibiotics. Now, urine normally is not sterile. This is a myth, but actually contains very low levels of bacteria. The problem is really when opportunistic infections occur. This is either down to an overgrowth of particular bacteria or an anatomical abnormality that may be present that's leading to an infection in a particular part of the urinary tract. Ultimately, this irritation and infection and bacterial colonization results in a number of different manifestations that patients will tell you about in a consultation. This includes urine becoming quite cloudy, patient experiencing low levels of systemic pyrexia, lower abdominal pain, dysuria, which refers to stinging sensation on passing urine, and this irritation ultimately resulting in patients going more frequently and even waking up at night, which is known as nocturia. Now, why do women get more urinary tract infections compared to males? The answer is anatomy. The female anatomy means that the urethra, which is the terminal part of the urinary system, is very short, measuring only about 3 centimeters on average. In males, however, this of course is dependent and this can change, but ultimately is much longer than the female. This means that bacteria have a shorter distance to traverse between the urethra or the tip of the urethra into the actual bladder, which makes it easier for bacterial colonization to occur in female patients. Now, for pharmacy first and pharmacists in particular, we're completely aware that there is a very specific PGD designed in order to facilitate your effective assessment and safe management of these patients. So the inclusion criteria for uncomplicated urinary tract infections include women around the age of 16 to 64 with suspected uncomplicated lower UTIs. The exclusion criteria includes pregnant ladies, which require their own regime of antibiotics sometimes, including MCNS, which is microscopy cold-chain sensitivities to be sent. This is in order to find out exactly what might be causing the infection. Other exclusion criteria include patients with a urinary catheter or recurrent UTIs, which is defined as 2 episodes in the last 6 months or 3 episodes in the last 12 months. Now, this should start you to think about some of the questions you may ask when you are consulting patients with a suspected uncomplicated UTIs. And of course, any patient that does not fit the inclusion criteria or has one of the exclusion criteria should be sent directly to general practice if you feel that they are well enough to do so, or emergency care if you feel that they are unwell. Now, what are some of the core features of a urinary tract infection? There are 3. The first is dysuria, which is a burning sensation. Often patients describe a needle-like sensation when they're passing urine. Nocturia, so you should ask what patients normally do at night, whether they get up in the middle of the night. Most patients will say maybe once or not at all. But if the patient is getting up much more frequently, then they have something called nocturia. Cloudy urine is another feature of urinary tract infections. Patients may describe things like smelly urine, cloudy urine, and other features include general urgency, frequency, going more frequently, visible hematuria, which is quite a concerning thing for patients, or suprapubic pain or tenderness. Now, if there are no main features, by main features we mean the top 3, then it's unlikely that a patient has a UTI, and they should be signposted to their GP so that they can be investigated for any other causes for their infection. There is a single main symptom, which is either dysuria, nocturia, or cloudy urine, then patients may have a UTI or may actually have something else. Therefore, they should be referred to a GP once again. However, if a patient has 2 main symptoms, then often patients should be asked to return to the pharmacy after 48 hours to assess if those symptoms are still there, in which case they can be given some antibiotics or ultimately reassessed and considered for some antibiotics, may I add. Now, how do we diagnose a urinary tract infection? And this is where some of your skills need to be put into good use, and this is where really your clinical acumen is tested. History. We've already spoken about some of the principles, asking patients about their symptoms, paying attention to the exclusion criteria, so making note of whether the patient has had a UTI before, in which case they may require an onward referral. And patients ultimately also need investigating. Think about some of the investigations you may do. Now, I would certainly think about doing a temperature, a heart rate feeling the pulse, blood pressure tests you could consider if you feel that they're unwell, respiratory rate maybe, but ultimately most patients will require an examination. But I would say at the minimum, doing a temperature is good practice, but with UTIs, because they are uncomplicated, the history is everything really. A really useful tool that you may have at your disposal is a urine dipstick. Now, it's important to know that if a patient is under the age of 65, but has 2 or 3 of the key symptoms of UTI, which we discussed in the previous slide, then you don't need to do a dipstick. You can just give them empirical antibiotics. Now, if the woman is under the age of 65 and has 1 key symptom of a UTI, then it's recommended to do a urine dipstick testing. Before doing a dipstick, the new scoring system is really useful. Being comfortable with doing basic observations really forms the mainstay of clinical practice. So get into the habit of feeling your own pulse and taking your own respiratory rate or somebody else's respiratory rate. Try and get used to using a blood pressure cuff. We're completely appreciative of the fact that many of you will be doing an independent prescribing course very, very soon, in which case you may be asked to perfect some of these skills and practice them in preparation for your OSCE. But if you're contributing to Pharmacy First, it's important that you do so now. And if you're not necessarily comfortable, then do tell your supervisor or your manager so that they can arrange some additional training. As for the urine dipstick, we thought we'd include a picture into this presentation. Now, we're looking for a number of different aspects to a dipstick. Now, there are loads of different parameters that one can focus on in a dipstick, but in the context of an uncomplicated urinary tract infection, we're looking for positive nitrites or leukocytes. And we're also potentially looking for any signs of red blood cells. If there is nitrites or leukocytes positive, then this patient is likely to have a UTI. If the urine dipstick is negative for nitrites but possibly positive for leukocytes, the UTI is equally as likely as an alternative cause for symptoms. So this is when you need to do a little bit more thinking. These arrows point out to what leukocytes look like and nitrites look like and what blood looks like. Now, if a patient is a female and of course there is a positive blood, then be sure to ask whether the patient is currently menstruating or not, because of course they would have a positive dipstick for blood if they were to be menstruating. Now, differential diagnoses are really important, and we completely appreciate that your training may not be as extensive as perhaps a medic, a physician associate, and an advanced clinical practitioner. However, this perhaps is the start of your journey into clinical practice as a pharmacist, and it's a really exciting phase, and you're very, very welcomed in terms of your expertise for sure. Differential diagnoses are important to keep in mind, and these are alternative diagnoses that may be actually at play. So asking patients about lower abdominal pain is very important, because lower abdominal pain could be a sign of appendicitis, constipation, gastroenteritis, pyelonephritis. And if you feel that there is an alternative diagnosis at play here, you shouldn't be shy in referring to the general practitioner. When it comes to dysuria, really ask about where or how often the dysuria occurs, because pyelonephritis or even renal stones and perhaps sexually transmitted diseases can also cause dysuria too. So ask about sexual encounters, ask about any flank pain or any visible blood in the urine. If a patient has temperatures as a mainstay feature, then they may have a viral infection or any other infection too. So what is really one of the main differential diagnoses you should really look out for, and one that the PGD specifically mentions as part of Pharmacy First? That is pyelonephritis. This is an inflammation of the kidney because of an infection. This infection typically starts off in the bladder like an uncomplicated urinary tract infection, but starts to move upwards into one of the kidneys or even both of the kidneys. This triggers an incredible immune response, which makes patients really, really unwell. White blood cells start to flood the kidneys, leading to swelling and pain. And ultimately, normal kidney function is impaired, causing complications like kidney damage, especially if not treated. Now, how do we know if a patient might have pyelonephritis? The PGD mentions this. Kidney pain or tenderness in the back under the ribs can be a sign. New or different myalgia, in other words, muscle pain or flu-like illness. Shaking, chills, or temperatures of more than 37.9 degrees. So it's important you really look at the temperature. And nausea and vomiting. If a patient has any of these signs and symptoms, then these patients require an urgent same-day referral either to the general practitioner or the relevant out-of-hours service. Now, what are some other, probably less serious differential diagnosis? History is important, so ask about vaginal discharge. A white creamy discharge with dysuria could be thrush. Patients can take over-the-counter thrush medication if required. Is there a possibility of pregnancy? If you're unsure, do a test. Dysuria and a possibility and pregnant woman will result in complications, and these require onward referral. How about the patient's medical history? Are they immunocompromised? Are they not suitable for just normal empirical antibiotics? Make sure you check this. Are there any genital urinary syndrome or symptoms of menopause, vulvovaginal atrophy? Now, this is not expecting you to examine the patient, but take note of the patient's age and whether their symptoms have existed over a few days, which is an uncomplicated urinary tract infection, or over several months. Take a good sexual health history. Are there any new sexual partners or any unprotected sexual encounters? And urethritis. In other words, is there inflammation post-sexual intercourse, or have any irritants or products been used around the genitalia? If any of these are present, then it's important to refer these patients either to general practice, an out-of-hours service, or even a sexual health clinic or GUM clinic. Remember, we're all part of a wider network of healthcare, so it's important that the different loci of healthcare are always talking to each other. As for the antibiotic choice, the PGD currently keeps it nice and simple. In patients with either moderate to severe, so that's 2 or 3 of the core symptoms, offer nitrofurantoin for 3 days, plus self-care, so encouraging patients to have more fluids and to have good hygiene measures. And currently the dose is 50 milligrams 4 times a day for 3 days, is currently the dose that's recommended. You can, of course, consult the BNF for cautions and any side effects, and be sure to check the patient's allergy. Safety net the patient well, because if the patient's symptoms worsen rapidly or significantly at any time, or don't improve within 48 hours, then they require an onward referral to general practice. Remember, once again, just a reminder for the inclusion and exclusion criteria. Any patient that does not fit these criteria, then they should be referred on. Now, what about self-care measures? Because if self-care measures are not instituted and you're not advising patients, then the antibiotics may not work. Encourage patients to drink plenty of fluids. It's so important. Aiming to drink 6 to 8 glasses. Ask patients to avoid alcohol, fizzy drinks, or even caffeine, as they can all irritate the bladder. For any pain symptoms, patients should be advised to take paracetamol or ibuprofen. Remember to ask patients if they've got any kidney impairment or any allergies to ibuprofen before recommending so. And there is very limited information and data about cystitis relief and also cranberry products to help improve patients' health, but patients may opt to take them anyway. Now, some of the other conservative or self-care factors include trying to stop bacteria from spreading from the bowel, so asking patients to wipe from front, i.e. the vagina, to back to the bottom after using the toilet. Patients should be encouraged to pass urine as much as they can, as opposed to avoid it because of the pain. Good hygiene is very important, such as urine after sexual intercourse, and even washing the external vagina area and genitalia is very important. Safety netting. Any serious signs of infection in the list below, patients should be encouraged to phone 111 for advice. If patients are not starting to improve after 48 hours of antibiotics, they require further assessment. If the temperature is above 38 degrees or less than 36 degrees, these patients need onward referral. If a patient's symptoms get worse, then they require onward referral. If patients have kidney pains in the back or just under the ribs, then 111 should be called. Any shivering or chills or muscle pain require additional care and concern. And if patients have not passed urine all day, then they may be in retention and therefore they require urgent referral and clinical care. If the patient starts to vomit or see blood or start to feel confused or drowsy, these are signs of sepsis and patients need to be made aware of these. So we're going to end this presentation with a couple of cases. Case 1, a 35-year-old female patient presents with lower abdominal pain and pain on urinating. She is 5 months pregnant. What should you do next? The answer is that because she's pregnant, the patient is excluded and is not part of the Pharmacy First program, and these patients need to be signposted to the GP. The next question is, what is the dosing for nitrofurantoin for uncomplicated UTIs? We went over this already, and some doses are really good to know off the top of your head. So it's 50 milligrams 4 times a day for 3 days in women. Now, a male patient presents with lower abdominal pain and dysuria. He's been experiencing symptoms for 3 days and believes that he might have a UTI. What should you do next? Now, these patients are also excluded because they are male, so therefore they should be referred to the GP. And finally, 40-year-old female presents with nocturia and lower abdominal pain. Urine dipstick is positive for nitrites and leukocytes and some red blood cells. What is the likely diagnosis here? The satisfaction central, of course. This is a likely urinary tract infection. And that's it for our presentation on Pharmacy First. Be sure to check out some of the other resources we have on offer for pharmacists and other allied health professionals. We have a fantastic YouTube page with great clinical history taking and tips and tricks on how to take good histories and examinations, so please do have a look at these. If you're looking to extend your knowledge about a number of different subject areas and you need some CPD accredited development, then log on to our website www.paretoeducation.co.uk/CPD, where you can see a number of CPD courses we have on offer. Feel free to join onto our social media platforms. Do follow us and do scan on to join our WhatsApp group as well. We look forward to seeing you on future events and welcoming you not only online but also face to face. Thank you very much for watching, and we hope that this was of benefit to you. Have a great day. Bye-bye.